It wouldn't let me because I put a title in, and I think it was reading on the title. Because now you know everything's AI and shit. So I wanted to present to you the next scamdemic. So here it is. Check him out. I do have his personal phone number, so we do exchange information. Well, we do. Yeah. So his name is James. You can find him. I don't think you could really see it, but I'll tag him in it. So here we go.
World Health Organization, our
Whoa.
headquarters here in Geneva.
So here we go, guys. Hear this shenanigans. Let's look at the shenanigans. It's just funny.
Hello to everyone from World Health Organization, our headquarters here in Geneva. My name is Tariq, and I welcome you to this special press conference following the first meeting of the Emergency Committee convened by WHO Director General and International Health Regulations regarding the upsurge of Mpox in 2024. We are happy to have a number of experts here in the room, a number of speakers also online, and I will just introduce some of them. With us is, as always, Dr. Tedros Adhanom Ghebreyesus, WHO Director General. We also have Dr. Maria van Kerkhove, who is Director at Interim Epidemic and Pandemic Preparedness and Prevention. With us is also Dr. Rogerio Gaspar, who is the Director of Regulation and Pre-Qualification. We have a number of speakers online. I will really would like just to welcome Professor Demi Orgoina, who is chair of the emergency committee and who is infectious disease physician and professor of medicine and infectious diseases at Niger Delta University and Niger Delta University Teaching Hospital in Bayelsa in Nigeria, and we'll hear from him a bit later. Before I give the floor to Dr. Tedros, for reporters online, if you would like to ask questions, please click the icon raise hand and you will be put in the queue. With this, I give the floor to Dr. Tedros for his opening remarks.
Thank you, Tariq. Good morning, good afternoon, and good evening. Mpox has been reported in the Democratic Republic of the Congo for more than a decade, and the number of cases reported each year has increased steadily over that period. Last year, reported cases increased significantly.
Guys, do you hear this shit? Dude, this shit is hilarious. Let's continue to hear the shenanigans that they're gonna pull for this year. Because you know election season's here, right? So you know election season's gonna be November. So you know they're gonna try some stupid shit before November. But let's continue with the shenanigans of the WHO. Let's continue.
And already the number of cases reported so far this year has exceeded last year's total, with more than 14,000 cases and 524 deaths. As many of you who tune into our regular press conferences know, WHO has been working on the Mpox outbreak in Africa and raising the alarm that this is something that should concern us all. Last week, I announced that I was convening an emergency committee under the international health regulations to evaluate the upsurge of Mpox in the Democratic Republic of the Congo and other countries in Africa. Today, the emergency committee met and advised me that in it.
Do you hear this shit? So, you know, back in 1980s, right? When the AIDS pandemic happened. Remember when Fauci went to Africa? Why is it always gotta be Africa? Why they always gotta be test labs? I don't understand. But let's continue.
Its view,
Let's continue.
the situation constitutes a public health emergency of international concern. I have accepted that advice. The detection and rapid spread of a new clade of Mpox in eastern DRC, its detection in neighboring countries that had not previously reported Mpox, and the potential for further spread within Africa and beyond is very worrying. In addition to other outbreaks of other clades of mpox in other parts of Africa, it's clear that a coordinated international response is essential to stop these outbreaks and save lives.
Hey, that way, you seeing this shit? Wow, I'm happy you're on. I thought I was here all by myself. You see this craziness? Dude, it's crazy. Let's continue though. Yeah, this is hilarious. Let's keep on.
A topical emergency of international concern is the highest level of alarm under international health law. The emergency committee's advice to me and that of the African CDC Centers for Disease Control and Prevention, which yesterday declared a topical emergency of regional security.
Yes, that way they're trying to push the monkeypox, bro. Yes. I didn't think you was gonna be on. Yeah, I was hoping. That's funny because I was hoping you was gonna be on. That's funny.
Are aligned. WHO is on the ground working with the affected countries and others at risk through our country and regional offices, as well as with partners including the Africa CDC, NGOs, civil society, and more. For example, we're providing machines to analyze blood samples and confirm cases of mpox. We're supporting laboratories to sequence viral samples. We're on the ground supporting case investigation and contact tracing, risk communication, and community engagement.
Did you hear what he said? Contact tracing? Didn't they do that with fucking the jab? We're not gonna say it because then I'm probably get censored, and I'm trying to keep some lives on YouTube. We're trying not to go liveless. We're trying to stay liveless. I mean live. Not liveless, live. But let's continue. It's hilarious. Right?
We're training health workers and supporting clinicians to provide appropriate care. We're supporting countries to access vaccines and develop the strategies to roll them out, and much more. To fund this work, WHO has developed a regional response plan requiring an initial $15 million. We have released about $1.5 million from the WHO Contingency Fund for emergencies, and we plan to release more in the coming days. We're also appealing to donors to fund the rest of the response plan. WHO is committed in the days and weeks ahead to coordinate the global response, working closely with each of the affected countries and leveraging our on-the-ground presence to prevent transmission, treat those infected, and save lives. I thank the Emergency Committee for its work and advice. And I would like to give the floor to Professor Amy Ogwoina, the chair of the Emergency Committee, to summarize the committee's considerations.
That way, that's hilarious.
Professor Ogwoina, you have the floor.
That's hilarious.
Thank you very much, DG. Let me say good afternoon, good morning, and good evening to everybody. The DG has given an overview of the constitution of the committee, the Emergency Committee on Upsurge of Mpox in 2024, and we had members that constituted them as members of that committee. And
that way, you're killing me, bro.
Today, 14th of August, this evening, a few hours ago, and 15 of the membership were in attendance. Essentially, our assignment was to determine whether the event, which is the upsurge of Mpox in parts of Africa, constituted.
Why do they always gotta attack Africa? Why? I don't understand.
We are required to base our decisions on the IHR criteria for declaring a public health emergency of international concern. So members of the committee listened to presentations from the WHO Secretariat on the global Mpox outbreak, risk assessment and current challenges, activities, and that that are taken by the WHO and including the WHO Afro region. Members of the committee also listened to presentations from most affected states parties, including the DRC, Rwanda, Burundi, South Africa, Kenya, and Uganda. Following this, members had a deliberative session where we looked at the three major criteria, which one, whether the current upsurge of mpox parts of Africa is an extraordinary event. And in the view of all members, it was unanimous that the current outbreak of mpox, upsurge of mpox, is an extraordinary event in view of the fact that we're having the highest number of cases ever reported in the DRC, for instance, since the outbreak was reported in the 1970s, especially 2024, a very significant upsurge in the number of cases. The fact that children, vulnerable children, pregnant women are also impacted, and a number of mortalities have been reported. Secondly, the emergence of a completely new strain of clade 1. Clade 1 is historically known to be more severe in clinical presentation and perhaps more transmissible than clade 2. And now there is an emergence of a new strain that is widely referred to as clade 1B. And what is also observed is that 1B is sexually transmitted. Also remarkable, making it an extraordinary event, is that this clade is now circulating in parts of Eastern Africa, up to about 4 countries. It was also remarkable to note that there's a resurgence of mpox in South Africa. About 24 cases have been reported this year alone, and amongst those cases, we have 3 mortalities. It is affecting especially people living with HIV and those with advanced HIV disease. We also looked at the second area for declaring a public health emergency.
You hear this nonsense? Do you hear this crazy nonsense? Do you, this is so funny. This is just funny. I like it. It just makes my day, because it's just like they think that we're so stupid that we're going to fall for this shit again. Like, and it's monkeypox. Like, really? Oh my God, it's going to kill us. We're going to stay home. We're going to have to stay home. Oh my goodness. We can't go shopping. Wait, you can't go on vacation. You can't go party.
International concern. And that relates to whether it has a public health risk of international spread. Evidently, the fact that the new clade that is sexually transmissible has spread to other African countries, and before now, these African countries have never reported a single case of mpox, including Uganda, Rwanda, Burundi, Kenya, reporting new cases of mpox, and the outbreak in Burundi, for instance, is very concerning because of the geographical dispersion of the number of cases that are reported there. So we believe that it's already a risk for international spread, and of course there is also the chance that it could spread beyond Africa to other regions of the world. The third is whether it requires an international coordinated response. Evidently, what we have now, this challenge of upsurge of mpox, requires a coordinated response, not only in Africa, but globally, so that collectively all parties involved can work to improve surveillance, diagnosis, and other public health.
Yeah, I'm going to have to check her out that way. What's her name? Wait, hold on. I got to write it down, dude. Hold on. Gotta write it down, dude. Hold on. Kimberly? Just chill, man. Just chill. She's from United Network News. Oh, okay. Sorry, I'm kind of slow over here. Doo-doo-doo. I had to go to the moment.
Health responses that are needed to nip this challenge at the board, in the board. So having done that, we made a recommendation, and all 15 members in attendance were fully in support of all elements of the criteria needed for declaration of a public health emergency. The second assignment was to advise on the proposed temporal recommendations, and those recommendations were made available in the following days by the WHO. But just to emphasize 3 points. One is that there is need for improved investment in understanding the natural history and knowledge gaps that are peculiar to, especially to Africa, regarding mpox. Ultimately, addressing these knowledge gaps and improving understanding will help to divide.
Hey, that way. Did you ever get Telegram? That way? Because all this stuff is on Telegram. Like, all the documentations from the shenanigans they're trying to pull again. Like, there's a whole plan and everything. It's crazy. Dude, the whole thing is crazy. I wish you could download Telegram. You have YouTube. You could download Telegram. And all the paperwork, everything that they have, they scripted out for the next scandemic, like what they're planning right now, like everything is on there. I did the work. Well, James did the work, and I just put it on my stuff, and so it could be easier for people to access what I picked up with what information he had. I just grabbed it. But let's go.
Preventive strategies and public health response, and the use of medical countermeasures such as vaccines and therapeutics and the likes. Also very important is the development of targeted interventions, prioritized targeted interventions that will address the problem according to the context in which the problems are being faced in specific African countries that are most impacted. At the background of all these recommendations is a continuation of the standing recommendations that, of course, we know that mpox is still ongoing in many other parts of the globe, and that there's a need for concerted effort by all stakeholders, not only in Africa, but everywhere else. So in summary, that those were the lines of thinking of the emergency committee and the basis of our recommendation to the DG, and that this should be considered for declaration as a public health emergency of international concern. I haven't said this. I would like to, on behalf of the committee, appreciate the DG and the WHO for inviting us and nominating us to serve to undertake this assignment. Back to you.
Thank you very much, Dr. Tedros, and many thanks to you, Professor Goina. It was a long day for you. We will now open the floor to questions from journalists, and we will start with Helen Branswell from STAT. Helen, please go ahead.
I want to know about the thinking of the emergency committee on use of vaccine to try to bring these outbreaks under control. Global supplies are limited, and one reads that it's estimated that 10 million doses may be needed and only 200,000 may be available. How is it going to be determined how vaccine will be distributed? Who will be in top priority? Which countries will get it? Who's going to decide that? Thank you.
Thank you very much, Helen. Maybe we can start with Professor Ogoina, and then we will see if we can have someone.
That way, every company is going to get it. Amazon, freaking Walmart. Like, they're all in it. They're all in it that way. Come on now. They're all in it. It's everybody. Even your fucking insurance, bro. It's crazy.
Anyone else to add? Professor, please.
Yeah, thank you very much for that question. So I think the issues of medical countermeasures, including vaccines, was extensively discussed by members of the emergency committee, and it was highlighted at that meeting that there are still gaps in access to vaccines, especially in
that way. That's why I had to make the video, because it's funny. So I just want, this is the conference that they just had. This is going to be for August. I forgot. You got to look at it. I think I screenshot it. I think it's a thumbnail, so I don't know. But, yeah.
many parts of Africa. And even when resources are available, in some situations, perhaps the global supply of vaccines may not be sufficient to address the needs of Africa. So this is an ongoing problem, but what is important is that all parties that made a representation at that meeting have recognized the importance of the elements, the concurrent element of vaccine in addition to surveillance, because it's very important that you understand your outbreak for you to ultimately decide what group of persons to vaccinate. And we have that gap in parts of Africa where we don't fully understand the transmission dynamics and the risk factors for mpox that is expected to guide who we're expected to vaccinate. And so all countries and state parties, and I think all the countries that presented had a costed plan, and some of those countries also had plans to ensure that they make a procurement of vaccines. And I believe the WHO is also working with countries and also working with manufacturers to see that they ramp up the production of additional vaccines that would address this challenge. Ultimately, in terms of regulatory approval for vaccines, countries like Nigeria and the DRC are already at advanced phase in terms of getting regulatory approval for use of vaccines, and I believe there are some donations that have been given, for instance, to Nigeria, and I believe also to DRC. And most of these countries already have some plans in distributing vaccines, but the challenge is that these vaccines are not sufficient, even if we need to use our theoretical knowledge to categorize the risk groups, including children, people with immunosuppression, pregnant women, healthcare workers, and the likes. Let me revert back to the page. Thank you.
Thank you so much, Professor. Let's go maybe to Dr. Tim Nguyen, who is online, and he is from WHO department dealing with high impact events preparedness. Tim, could you please come in?
Well, thank you, Demic, and Helen, thank you for your question. I'm happy to give some information about our latest understanding about availability and accessibility of some of these vaccines. We're concretely talking here about two types of vaccines that have been used in the last 2 years by some member states in response to the control of mpox, which is the MVA-BN vaccine and the LC16 vaccine. We have been in contact recently with manufacturers this week to have understanding of the availability at the moment. So when it comes to the MVA-BN vaccine, currently about 500,000 doses are in stock at the moment that can be procured by countries or other entities. Another 2.4 million could be produced by the end of this year if buyers are there to make a firm procurement request. And for 2025, there could be another 10 million doses produced, but there needs to be a firm request for those manufacturers to plan for the production of these vaccines. So that's what is our understanding around the MVA.
Hold on, I'm reading your comment. Yeah, but this was just posted on their website. This is from the conference that they just had. So this is the conference. This is what they're trying to do. It's on their website. This was live the other day. So he posted it yesterday. So yeah, see, like, where is it? See right here. August 14th. This happened today. See? You see the date, the 14th. August 14th, 2024. Let's continue to hear their shenanigans. So they just did this today.
At the moment. At the same time, we work with our partners through the so-called IMCM Net partnership, specifically here with Gavi, the Vaccine Alliance, and UNICEF to work on a donation scheme for those countries that have stockpiles, that have reserves of the vaccine, and best to donate them to recipient countries that are in need. We're building these donation scheme for the purpose of understanding where to best use them when resources are scarce, and where we can use this limited accessibility of donated vaccine to have the biggest public health impact around this. When it comes to the LC16 vaccine, this is a very special vaccine in terms of that this vaccine is not commercialized, but at the moment produced on behalf of the government of Japan. In previous incidences, the government of Japan was very generous when being asked.
Very generous. Very generous.
And this is also one way for WHO to work with countries and with the government of Japan to facilitate donation of the LC16 vaccine, which has a considerable size in their stockpile at the moment. I stop here. Thank you.
I want to emphasize two important points that were made. One is that we need a much better understanding of the epidemiology in the affected countries and the at-risk countries. We need to understand the transmission patterns. We need to understand the populations that are risked, and it's dynamic. There are multiple outbreaks that are happening. There are changes in terms of what we're seeing in the epidemiology itself.
Yeah, do you see the psychology they're pulling on fucking everybody? They're gonna try to pull on everybody. You see, and like she thinks like we can't read between the lines. She's fucking retarded. That's all I gotta say. She's fucking retarded.
Understand that better will help us to use the limited numbers of vaccines that we have in a targeted and a most appropriate way. So I want to stress that one point. And secondly, to request if there are countries that have vaccines to donate to come forward and to work with us through the IMCM Net partnership that Tim has just mentioned. We need to have a good visibility on what is available and how those could potentially use. And of course, support the countries with protocols and making sure that as part of the response, vaccines are used. Last point is that vaccines are one intervention that can be utilized.
It's a shit show,
but we do know that there's such strong country work, community work in terms of risk communication, community engagement for prevention activities. And we have seen with the global outbreak, though it was due to clade 2, and here we're really talking about clade 1b, there are a lot of interventions that can be utilized in country, in communities to prevent transmission.
Thank you, Dr. Magick. Indeed, we have many questions lined up, so let's try to take some. Let's go to Bloomberg. We have Janice Q. Janice, please mute yourself.
Hi, thanks very much. Two quick ones. Could you maybe explain what happens next now that it's an official emergency? And my understanding to date is that there is no confirmation that there's an airborne element to the spread. But if you could maybe just talk to that and confirm if that is correct.
So perhaps I can start. So as Professor Ngoya said, that the emergency committee is working on drafting some temporary recommendations for the consideration of the Director General to issue. So that is something we expect to be able to release in the next day or two. The teams are working on it very hard, even as we speak, as we are sitting here. And so with those targeted temporary recommendations, there will be some advice for member states, affected member states, at-risk member states. I also want to highlight that the Director General extended the standing recommendations for MPOX for another year. He mentioned that at the press conference last week, and those are online. We can put that link in the chat. With regards to transmission, there's multiple modes of transmission that we really need to better understand. Primarily what we are seeing is the contact type transmission. We have seen sexual transmission, which is really what is concerning us. And now we have seen this virus, the different clades, and in particular clade 1b in sexual networks. And this is where we need to have targeted interventions, stronger surveillance, stronger contact tracing, stronger risk communication, community engagement with affected communities, with CSOs, with people on the ground so that we could limit that onward spread. We've said this before. You've heard DG say this. You've heard Mike say this many times. We can stop transmission of Mpox with a concerted effort using multiple approaches in terms of looking at how the virus is transmitting in which populations. We do see transmission among families as well. We do see zoonotic transmission in addition to that. So these are the primary ways that we are seeing this virus spread.
Thank you very much, Dr. Magick. Let's move to next question. We have Priti Patnaik from Geneva Health Files. Priti, please go ahead.
Hi, good evening. Thank you for taking my question. I have just two quick questions. One is on the status of the emergency use listing, if there could be an update on that. And second, my understanding is the amended IHRs will not apply to this particular emergency because they come into force only 10 months from now. If you could clarify that. And just another small question on, you winded down the declaration of a fake for Mpox for another strain last year. But do you think that would have the world lost time in some sense? If you could help us understand that. Thanks.
Thanks, Priti. We have really many questions, many reporters online waiting. So let's try to really limit the number of questions per reporter. But let's try with let's go with the pre-qualification with Dr. Rogerio Gaspar, who is Director of Regulation and Pre-Qualification, and then we will see if we can answer the questions.
Okay, thank you, Tarek. So regarding the emergency use listing, and just to remember that the emergency use listing is a temporary measure to be used in a particular situation, can be used outside of the FAQ, and that's why the Director General triggered the emergency use listing process last week, even before the meeting of the IHR. The Department of Regulation and Pre-Qualification, through the Pre-Qualification Unit, has been in contact with both manufacturers of vaccines, but also with therapeutics and diagnostics for the last 2 years. As the emergency use listing was triggered last week, we accelerated the contacts with the companies, and I can announce that one of the companies is prepared to submit most of the documentation needed by this week, by the end of this week, and we have a critical meeting with the second manufacturer of another vaccine beginning of next week. So our work schedule right now, we are pointing for convening the technical advisory group, the expert committee that will propose the adoption of the vaccines under the emergency use listing around mid-September, and our team has already convened the experts for that technical advisory group with 3 tentative dates for the mid of September. So this is our timelines right now.
Thank you very much, Dr. Gaspar. Let's maybe go for the second question. The question was about international health regulations and the amended regulations. Let's go to Roberta Andraghetti, who is from International Health Regulations Secretariat. Roberta?
Thank you, Tariq, and thank you for the question. The amended the emergency committee today was informed that they were operating under the provisions of the IHR adopted in 2005 and entered into force in 2007, and not to worry about the amendments adopted by the 77th World Health Assembly in May. Those amendments will be entering into force 12 months from the date the DG officially notifies state parties about the amendment, and at present, as requested in the adopting resolution by member states, there is a linguistic conformity and accuracy check of the translation in the 6 different languages. Then once we have concluded that accuracy check process, then the Director General will be formally notifying state party in the 6 official languages, and the amendment will be entering into force in 12 months from that. Over. Thank you.
Thank you very much, Roberta. Let's move on, and if it's possible, really to have one question at the time. Catherine Fiancambokonga from France 24. Katrina, please go ahead.
Thank you, Tarek. Good evening to all of you. My question is related to the spread, and particularly in the other parts of the globe. As we know that countries like Uganda, Kenya, Rwanda are very touristic countries, and people are coming from abroad to visit the country. So what is the situation for the moment, and also about the funding? I suppose that the funding is needed, highly needed, and what is the situation? Thank you.
Thank you very much, Catherine. For the first question, maybe we start with Professor Ogoina about the situation in African countries.
Thank you very much. Regarding the situation in African countries, from January to perhaps July or so, we have, let's talk about the most impacted African countries that are witnessing this upsurge. So DRC, for instance, has over 14,000 confirmed cases, and of course this is an underestimation because a number of the cases in the DRC are not tested, and as such, it's likely that there's a significant underreporting in the DRC. Kenya has reported 1 case, Uganda has reported 2 cases, Rwanda 4 cases. Burundi has reported, I think, about 100 cases. And as I said in my earlier remarks, that the situation in Burundi is actually of concern because the cases are reported within a space of a month, and they were affected about 22 or 23 out of the 40-something districts in the country, which is actually very remarkable and suggests that there was an ongoing, unrecognized transmission, human-to-human transmission in that country even before the first case was detected. In South Africa, 24 cases, as I said earlier on, has been reported this year, and 3 of those cases have died. Those deaths were amongst people with advanced HIV disease. What is also important is that we are seeing a trend that sort of parallels the historical knowledge of the HIV pandemic, where disease is being transmitted from one country to the other through various networks, including sexual networks and even travel. So long-distance truck drivers have also been known to be exposed and also had confirmed cases moving from one country to the other. So amidst this number of cases, in some of these eastern countries, of course, Cote d'Ivoire is also reporting new cases. Is the challenge of the likely challenge of underreporting of cases, and the fact that Mpox, especially the new type of Mpox that is sexually transmitted, may present with atypical lesions, and a number of people may not present in the formal healthcare setting. So many of the members, for instance, in the emergency committee, are of the view that what we have in Africa is actually a tip of the iceberg, that we have a greater challenge. Because of weaknesses in the health system, we are not recognizing, or we don't have the full picture of this burden of Mpox. To that extent, there is need for us to strengthen surveillance and invest more in surveillance and embed research in our surveillance efforts so that we can uncover the gaps that relates to the challenge of Mpox. Over to you.
Thank you very much. Let's just maybe go to hear from Dr. Salam Guy, who is Regional Emergency Director in WHO African region, who can add something briefly on that. Dr. Salam, can you hear us?
Yeah, the chair has already said it.
We
have so far in Africa 2 countries that we have reason to believe that there is community transmission, which are DRC and Burundi. For the other countries, though, you talk about Kenya, Uganda, and recently Cote d'Ivoire, it is isolated case, and so far we do believe that there is no community transmission. It should be noted that in most African countries, over 40 or 47 countries has a very effective, robust surveillance system, that may miss some cases, but it would be very difficult that they miss a whole outbreak that is happening in the country. We are still working in order to reinforce that for all the continent, and also to make sure that there is cross-border collaboration that would allow that anytime that there is inclusion of cases in another country, we will be able to detect it as soon as possible and respond. All the teams are in place at all the countries in Africa, and we are working, and as said, it may need additional resources. Yeah, whatever we have, we are using the optimal way of them. Over.
Thanks. I'll just briefly address the funding question. I know you want to get to more questions, but just state what the DG said, that there's a regional plan with an initial ask of 15 million. So we were going to be looking at the regional plan. We're going to be looking at this multi-country outbreak and a response, working with all of our partners to come together with a consolidated ask. So that number will increase, but right now it's an initial 15 million, and we're asking countries, we're asking funders to come forward to support that implementation.
Thank you very much. Let's go to the next question. If it's really possible to have one question. A reporter, Christian Ulrich from German news agency DPA. Christian.
Thank you, Tarek. Yes, it's just one question. With the clade 2 outbreak in 2022 in many European countries, people got the impression that it's a rather mild disease, and if you take care of yourself, you will heal and it's over. What is the difference now in the outbreak now? Why are we so concerned? How lethal is this for people who get infected? Thank you.
Perhaps I can start with that one, and others may want to supplement. I think, we did see this global outbreak of clade 2, 2022, 2023, largely brought under control with community action. And there are many people who suffered with infection from Mpox and the disease that it causes. And I can tell you for them, it wasn't considered mild. We do have some information on clade 1b, that it's more severe than clade 2. But I do want to stress here, and I think the professor mentioned this, there's a lot of uncertainty that we have. We really need detailed studies. We really need to understand not only the transmission, but we also need to understand the natural history. We need to see the disease patterns. We need standardized data collection on the patients that are infected with Mpox, so that we could better understand the disease course, the severity of this, and most importantly, to make sure that not only are we focusing on prevention measures, but we're utilizing therapeutics and having therapeutic guidelines updated based on the evidence that we have. So there's a lot of work that's underway to address these unknowns, and there really needs to be a concerted effort to better understand this. We have an opportunity right now to really leverage this time and support our member states, to support the research that needs to be done to understand this. I'm not sure if others would want to comment on that.
Do you want to hear from Chair Goina?
Yeah, so, yeah. I think the comment I'll make regarding the severity of Mpox, regarding clade 2, well, majority of cases during the global outbreak, especially in the global north, we had mild infection. And for those that had severe disease, a substantial, significant number of them had concomitant HIV or advanced HIV. They were immunosuppressed and perhaps not virologically suppressed. I think the challenge here for Africa is, as I said, is also the uncertainty. We know that Mpox, HIV co-infection, especially for those with advanced disease, are associated with more severe manifestation and even deaths, and there's evidence from publications in Africa that alludes to that fact. So we're having a situation where we're having a new clade that is known or thought to be more transmissible, more serious, being circulated in all parts of Africa. We still have clade 2B in Africa, and Africa is a place where we still have a number of the population that are either not diagnosed because they are not, the routine testing for HIV is limited, or even when they are diagnosed, not receiving antiretroviral drugs. And when they are receiving antiretroviral drugs, they are not virologically suppressed. They are not taking sustained antiretroviral therapy. So the challenge here is that the one front of the challenge is that that if we don't address this problem at this phase, we may get to a point where this virus, either the clade 2B or the 1B or 1A, can go into the HIV population, especially those that have advanced HIV and not virologically suppressed, and we have a significant number of persons that are coming up with severe disease and deaths. Also remarkable in Africa is that the number of deaths have been reported in the DRC affecting mainly children. Most of the deaths are in children, and we are getting a trend now where Mpox is transiting to heterosexual transmission from gay and bisexual men. We are seeing heterosexual transmission. And the implication of that is that it will ultimately impact on pregnant women. And so we have vulnerable groups, children and pregnant women that will ultimately...
See, now you see how they're trying to, like, use, like, pregnant women? This is crazy. That's ridiculous. You see this craziness? This is crazy.
Bear the brunt of this disease, and that will result to all sorts of complications and severity. So I think the idea is looking at the big picture and saying that we need to act now so that we avert the challenges that we foresee in the future. Thank you.
Thank you so much, Professor. Let's try to take one or two more questions. Rory O'Neill from Politico. Rory, could you please go ahead?
Thank you. Good evening. I think we started to touch on it there, but I was just wondering if you could confirm that children are still being disproportionately affected. This situation report in June, I think, certainly confirmed that, but we've had a lot of cases since then. So I was wondering if you could confirm we're still seeing that pattern bear out where children under the age of 5 are being infected at a disproportionately high rate. Thank you very much.
Thank you, Rory. Professor Goina, would you like to take this one?
Yeah, so the reports and presentations that we had during the emergency committee meeting emphasized that children are the worst impacted in the DRC, especially in areas where we are having historically endemic infections. Children are the worst impacted, but in the South Kivu also, the epidemiological picture is a bit different. Most of the cases are commercial sex workers and heterosexuals and young adults that are most impacted. The findings from Burundi, from the presentation from the state parties, suggest that most of the, close to 60% of those that are impacted are less than 15 years of age. And the most affected group are those below the age of 5. About 38% of those are impacted are below the age of 5. If you then go to countries like Nigeria, South Africa, most of the persons impacted are young adults between the ages of 20 to 40 years. So you will see that it's a mixed picture. But specifically in the DRC, if you're looking at the cumulative figure, you will say that children are the most impacted. Thank you.
Thank you very much. And if I may just, our reporter from France, Catherine, we have misunderstood her question. She was in fact asking about cases outside Africa. So if we can just
well, look at what happened with look at what happened in 2020, dude. So everybody better like literally be prepared. Like this is ridiculous.
Happening outside Africa. I don't know, Chair, if you can talk about that.
Yeah. So I think the report outside Africa, if I remember correctly, there are a few cases that have been reported outside Africa, and those cases perhaps are less than 100. I can't remember the exact figure now. I know remarks were made that is it the Eastern Mediterranean region? Again, I don't want to give WHO will have to correct me on this, but essentially, I think the report indicated that there has been either significant decline and in a number of cases, and but cases are still being reported in the different parts of the globe. That tells us that there is some.
Yeah, that's hilarious. that was a good one though. That was a good one. I'm not gonna lie, that was a good one. That was a good one.
Ongoing transmission, and I think in that presentation, members also observed that the WHO noted that some countries, including countries outside Africa, perhaps are also not reporting cases to the WHO and perhaps are not as proactive as they used to be during the 2022-2023 outbreak. And to that extent, it is possible that there is also an underestimation. Perhaps there's another underestimation of cases in outside Africa. I think there was also a report on the number of cases that have been reported in the literature, but also not reported to the WHO. So there's an ongoing transmission outside Africa, but not as significant as what is happening in some of regions in Africa. I hand over to the WHO.
Thank you so much, Professor. And then maybe we can go to maybe a last question. We have Paula De Poggio from The Lancet. Paul?
Thank you very much. So my question is on closing the gap between suspected cases and confirmed cases. So what is the current approach towards improving diagnosis and testing so that we have true picture of the confirmed cases over suspected cases? That's my question. Thank you.
Thank you very much, Paul. Just checking who could, maybe Dr. Vakirko, would you like to try?
I can. I can't. I was going to ask if the chair wanted to go first, but maybe he would like to supplement because this was discussed quite a lot among the emergency committee members, and this is something that's discussed among the WHO Secretariat with our member states, with our expert networks. To close this gap, to really understand the extent of infection, we need stronger surveillance in countries. First, to be on the lookout for Mpox. There are other concurrent outbreaks that are happening with measles, for example, chickenpox. So we need strong surveillance and good diagnostics. Our diagnostics teams are working to better understand the use of the current PCR test, the other tests that exist that are out there, to distinguish between clade 1, clade 2, and so there's some improvement that's needed certainly there. The other thing is, of course, access to these tests. We saw during COVID a lack of access.
See, look at this case. Look at this.
Countries, and we're seeing that here as well. So part of the work that we are doing is not just trying to look at access to vaccines and therapeutics, but also access to diagnostics. So across the spectrum of having stronger surveillance, where we have surveillance, making sure that we have good contact tracing. So when we identify a case, we look at the exposures of others in the context so that we can prevent the onward spread, making sure that we have accurate, reliable, affordable diagnostics, and making sure that those are accessible in countries, working with manufacturers of diagnostics to make sure that those reach the countries in need. If there are requests for diagnostics from countries, that is something that we need to be aware of. We are aware of several, and we are looking at how we can get those those diagnostics into country.
Thank you very much. Professor, would you like to add something to this?
Just to say that it's important that hello.
Yes, we can hear you.
I think the challenge of testing is significant, especially in the DRC, where perhaps less than 30% of cases. It has increased over time because of some investment from the FIG that was declared in 2022 and support from partners, both at national and non-governmental organizations. And I'm aware that it was actually presented at the meeting that GeneXpert, for instance, has been deployed to the DRC to improve diagnosis. So members emphasize the need for us to the globe, all the health authorities to invest in improving diagnosis, especially in the DRC, where cases are not being tested, and that is a significant challenge that needs to be addressed, because ultimately we are working blindly if we are not able to test all suspected cases, and that also demands research and development to develop more innovative, more cost-effective, and more accurate point of care diagnostics that can be deployed to rural settings, because one of the challenges of diagnosis in the DRC, for instance, is people live in and develop mpox in remote areas where they don't have access to the city centers where these diagnostics labs are situated. So there's a need to decentralize and look for more cost-effective point of care diagnostics that can be applied to improve the test rates for cases of mpox in various parts of Africa. Thank you.
Thank you very much, Professor. And we will take one last question, and then we will be at the hour.
Come on, this is boring.
To Jennifer Rigby from Reuters. Jennifer, please go ahead.
If you can hear me, what I wanted to ask is going back to vaccines, just if there's any timeline for when any kind of campaign could happen in Congo or the other affected countries. We've heard sort of October as a best case scenario, but I just wondered if WHO has any guidance on that.
Thank you, Jennifer. So on the vaccination countries, maybe we can see with Dr. Salam and also Chair if they could say something about this. Dr. Salam?
Thank you very much. Actually, given the amount of vaccine that are available in Africa, I know that in DR Congo and Nigeria, a campaign may not be the most appropriate way to stop the outbreak. It should be evidence-based with epidemiology and very targeted intervention that we will be advising. The work is ongoing on the regulatory side in parallel with the AP and the implementation science that we are looking for. So likely the first countries to go for vaccine will be DR Congo that already have a proposal of vaccine. Nigeria also is advancing with our colleague from Africa CDC. They are also working with us in parallel. Thank you very much.
And Professor Ogoina, would you like to add something on this last question?
I fully agree. I have nothing to add to what Dr. Abdullah said.
Thank you very much. Well, with this, we are bringing this press conference following emergency committee meeting to the end. We will send video footage of this press briefing, as well as the opening remark by Dr. Tedros by email, as we always do. And now I will give the floor to Dr. Tedros for his closing remarks.
Yeah, thank you. I would like to thank Professor Ogoina for chairing the emergency committee and also for his presentation and participation in this presser, and through him also to all members of the emergency committee. And I would like to thank the members of the press for joining us today, and see you next time.
Oh, we're gonna watch that tomorrow, guys. We're gonna watch that one tomorrow. So I wanted to show you the shenanigans. Get ready, because you already know it's coming, right? Don't fall for it. Welcome to the next Scamdemic of 2024. So I will catch you guys later. Adios. Bye.